Good afternoon, everyone. I want to welcome everyone to Care Connection, which is our free live webinar, the second Thursday of each month, and periodically we also have special edition webinars. Today is our special edition Care Connection. Our topic is special considerations for individuals living with post-traumatic stress disorder and dementia. We have two very special guest speakers that will be presenting today's information. We have Kathy Jonas. She's a program administrator at the Texas State Veterans Home Division of the Veterans Land Board. In addition, we have Sarah Rodriguez, a registered nurse, and she is a quality nurse manager at the Texas State Veterans Home Division of the Veterans Land Board. So before we begin today's presentation, could both of you tell us a bit about yourselves? Thank you.
Hello, everyone. This is Kathy Johans, and I just wanted to thank you, first of all, for joining the webinar. Sarah and I are very excited to share what we've learned over the last couple years about caring for elder adults with dementia as well as post-traumatic stress. So we will get started in just a few minutes, but to let you know, the state of Texas has 8 military veteran nursing homes where we serve about 1,100 veterans per day in those homes. And most of our veterans currently are Vietnam War era veterans, so they have a lot of trauma that has never been diagnosed or managed. So we deal with a lot of what people term as behaviors in our communities, and we've put together this training to help folks who have people that they're caring for have trauma experience or military experience to better understand what they're going through. So Sarah, what do you have to add to that?
Not much. We thoroughly enjoy what we do. We believe we've made some significant strides in tying PTS and dementia together, so it does make a little bit more sense and is extremely applicable to the population that we serve, and we thank you very much for taking your time to listen.
Okay, so let's get started, and you'll hear Sarah and I are going to go back and forth on this presentation. So Sarah's going to handle most of the nursing and clinical aspects, and I'll handle most of the post-traumatic stress aspect. So what we're going to talk about today is we're going to define post-traumatic stress, dementia, and behaviors, we'll give you a basic understanding of post-traumatic stress, what some of the triggers are, particularly with the military veteran, how to proactively avoid the triggers. Sarah will go into the brain changes and the similarities between post-traumatic stress and dementia. She'll talk about commonly exhibited behaviors and appropriate staff interventions. We use what's called the STAR VA card to identify behaviors and how to work at what was the root cause. She'll talk about communication and medication, and then we'll end with survivor's guilt, moral injury, and end of life, because we have found that most of the people that we work with who've had trauma experiences, if they haven't reconciled their trauma and they get to the end of life, they oftentimes have issues that they need to address and that come up for them and keep them from having an end-of-life positive experience. So post-traumatic stress, we do not use the term disorder. We use just post-traumatic stress because not everyone who has had trauma and are still dealing with the past trauma have it to the point of a disorder. And it keeps people from getting help sometimes or addressing their trauma. In the military, it's also being called combat and operational stress reaction. So that is the expected and predictable emotional, intellectual, and physical response of a veteran or other person who's had trauma, who's been exposed to stressful events in war or military or other trauma other than war. It causes a subtle physical change in the brain. It's when stress is too intense, it lasts too long, or it's a continuous event. Veterans have told us that their body keeps score, that they don't want to remember the sights, the sounds, the smells, but every time one of those instances occurs, they automatically have a bodily reaction to that. It affects the brain's ability to handle and adapt to stress, sight, sounds, and memories, and it's a normal reaction to an abnormal situation because most trauma be it military trauma, sexual trauma, child abuse, natural disaster trauma, any of those types of things are not the norm, and that's why it is a normal reaction to an abnormal situation.
So to define dementia, dementia is actually a loss of mental ability that's severe enough to interfere with the activities of daily living, such as bathing, dressing, grooming, toileting, walking. Dementia is a group of symptoms that causes gradual death of the brain cells. Dementia is not a disease. You have to have a disease with dementia symptoms, such as Alzheimer's disease or Parkinson's dementia, AIDS dementia. It's the loss of cognitive abilities that occur with memory, reasoning, planning, and behavior. And the example we use for this is in one of our properties, we had a veteran that we'd wake him up in the morning and lay his clothes out and ask him to dress, and then we'd come back and get him for breakfast. And one morning, nurse aide goes in, lays his clothes out, and explains it and tells him she'll be back. Well, she gets out of the room, and here in a minute she turns around, and he's standing in the middle of the hall with his shoes on, but he's naked. So, of course, the first response is, oh, he's being sexually inappropriate. But that's not necessarily the case, because what has happened is he can't plan, and it takes planning to put on your underwear and then your breeches and then your shoes. So the last thing he saw was his shoes, and he remembered how to do that. Dementia is not an inevitable part of aging, and people with PTS, it is proven, are twice as likely to develop dementia symptoms. If we were going to define behavior in one word, it would be communication. So it is the observable activity of a person in response to either internal or external stimuli. Internal stimuli would be that they're cold, they're hot, they're hungry, they're hurt, they're frustrated, they're bored. External stimuli would be a roommate's hollering or somebody's voice that irritates them. And we need to determine what they need right now. We also need to decide and pay attention to the fact, is it an abnormal behavior, or is it something that's a normal reaction? So if you were standing with your back to somebody and they walked up and spoke your name and it startled them and you just kind of slung your arm and hit them, their response to you is going to be an apology for having startled you. Whereas a lot of times in our settings, somebody will be kind of daydreaming and we'll walk up behind and speak their name, and when they turn and their arm hits us, then we say they're physically aggressive. Well, it's at that point that we need to determine, if I had been approached in the same way, would my reaction have been the same? When we talk about behaviors, we talk about behaviors escalating and how we need to get it when it's at the lowest level before somebody gets so frustrated that they have to be aggressive to get our attention to figure out what they need. So the levels of behavior we're going to discuss are anxiety, defensive, and risk behavior, and what we need to do to be supportive and hopefully de-escalate the behavior. So with anxiety, we need to be supportive. With defensive, we need to be pretty direct. And with risk behavior, we need to intervene. So anxiety is a noticeable increase or a change in behavior. And in all honesty, the best response to that is a non-judgmental approach and just asking either what happened, and look them in the eye, what happened, or what can I do? Because that gives them a second to turn around and think about what it is that happened. And they don't necessarily have the words, but we can figure it out better at anxiety than we can at defensive. Whereas if we miss the anxiety and they move to the defensive behavior, they begin to lose the ability to be rational. So if somebody was anxious and irritated and I turned around and asked what happened, and they told me that the person sitting next to them stole their coffee, and I could tell them, oh, I'm sorry, I took your coffee to get you fresh, and they can kind of process that, then they're rational. But if I say the same thing and their response to me is, you're lying and he stole my coffee, they're irrational. And there is nothing that's going to come out of my mouth that's going to be able to get them to understand what I'm trying to tell them. So my approach to that is, I am going, if they're insistent that whomever is sitting beside them is who stole their coffee, then it makes sense that I would block his view to that person, because the more he looks at that person, the madder he's going to get. So if I step to the side that blocks his view of that person, and I encourage him to come with me, then I can redirect the behavior and hopefully alleviate it. If I have missed the anxiety and the defensive portion and we get to risk behavior, this is where somebody is going to get hurt, either the veteran himself or somebody that's around him. And at this point, I have to disengage him. So I need to move him. If he's not going to come with me, then I need to move any potential victim that's in the way.
Okay, so we need to have a basic understanding of post-traumatic stress so that we can understand who we're taking care of if they're a military member or past military member. So a difference in society's perception of a war plays a significant role in how people who've been traumatized by military experience manage that. So we are currently taking much better care of our veterans who are coming back from Iraq and Afghanistan during this war process than we did in any other previous war. We are sending our troops home from their war experience in airplanes full of veterans who have the same experience. They're able to talk with each other. They are able to discuss what their experience was, and so it's almost therapeutic for these veterans. And then when they get home, they're coming home to a large crowd of people who are thanking them for their service and for the role that they played in protecting our nation. But if we look back at how we took care of our veterans from other wars, we're not doing the same thing. Because World War II was very welcoming home to our veterans. They basically saved the world from the bad guy. And when they came home, there were ticker tape parades and kissing in the street, and our society was in a very good place. But when our Korean War veterans went off to war, it wasn't even considered a war. They were told that they were providing a policing action in Korea. So they were not welcomed home as a veteran who had saved the nation. And of course, our Vietnam veterans came home to a political firestorm. So people have said, if you are against the war, you are against me as a veteran. Another factor that plays a role in trauma with our veterans is age. So the average age of a World War II or Korean War veteran was 27 years old. Well, when you're 27 years old, you have life experience that will get you through a lot of trauma. You can say to yourself, I've got a wife, or I have children, or I have a family, or I have a job, I have a home, I have something to go back to. I've lived enough life to know that I'm going to be okay when this is over. But the average age on paper of our Vietnam veterans was 19. And actually, in reality, it was more like 17. So when you're 17 or 19 years old and you go off to combat, you do not have life experience to tell you you're going to be okay to get through this when you get back home. So the other factor that plays a role is how our veterans come home from war. So our World War II vets came home from Europe in ships, and it took them about 30 days to leave Europe and get back to the New York harbor. So again, they were with people who'd been through similar circumstances. They had seen horrible things. They had to do horrible things to survive and protect their brothers and veterans. So they talked about that. They shared experiences. By the time they got back, they had, again, had some self-therapy to get through their trauma. Our Korean War veterans, and particularly our Vietnam veterans, came home individually on airplanes. And they were told, do not wear your uniform on the plane home because if you're sitting next to someone who is against the Vietnam War for 30 hours on an airplane, it's going to be a very uncomfortable flight. So when our veterans got back from Vietnam, they got off a plane in San Francisco, they went to an out-processing center, and they signed a piece of paper that basically said, I served in Vietnam. They signed another piece of paper that said, I am now home from Vietnam, and they were walked out a door. And when they walked out the door, they were met by people who were against the war and against the people who fought the war. And they were oftentimes called baby killer. They had urine and feces thrown at them. They were spit upon. And no one asked them, are you okay? Do you need to speak to somebody? Have you experienced trauma that you need to talk about? So they were basically just kind of put out in the cold. And oftentimes, post-traumatic stress reemerges later in life. It's called delayed onset of PTS. And most of the people that we care for in our homes, our elder veterans, never dealt with their post-traumatic stress. The post-traumatic stress diagnosis didn't come into play until 1980. Well, our Vietnam veterans were coming home from Vietnam in the early 60s to the mid-70s. So they were not able to be diagnosed or treated for their trauma symptoms. And I have to tell you a personal story here of this is what happened to my dad. My dad served in the Korean War and Vietnam. He came home from Vietnam in 1967. He was finally diagnosed with post-traumatic stress in 2008. So what my dad did to deal with his trauma was he smoked, he drank, and he self-medicated to manage his trauma symptoms. So my dad in 2011 was moved into a nursing home for the last 7 months of his life. Well, as you know, nursing homes are highly regulated, and we can only allow our residents to do certain things. So during his admission process, the director of nurses and the administrator said, we're very happy to take care of you. Thank you for your service to our country. We understand that you smoke, so we have a smoking schedule here, and we go out 4 times a day. Well, that made my dad a little nervous because he was smoking about 2 packs of cigarettes a day at the time. It helped him to manage his anxiety. So he was nervous about that. Then they said, we know that you drink, so we're going to get you a doctor's order for 1 drink a day. Well, I need to share with you that my dad was drinking about a 12-pack of beer and a half a bottle of Jim Beam at night to go to sleep because he had night trauma. So every time he'd go to sleep, nightmares would occur, which he couldn't control, so he wouldn't allow himself to sleep. So he got into this vicious cycle where the only way he could get to sleep was to be inebriated. So when they told him he was going to have 1 beer a day, he got really, really nervous. And then finally, they said to him, we know that you have anxiety, so when you're feeling anxious, please just let the nurse know and she'll give you a pill. And that's when my dad lost it. He said, there's no way that I'm going to go to a young nurse and tell her or him that I need to have a pill because I'm anxious. So his delayed onset PTS escalated because he was not able to manage his trauma symptoms based on the coping mechanisms that he's been utilizing in his life since 1967. And this is what happens to a lot of people who have trauma who they haven't dealt with, and then we have to, through their dementia process or their illness process, that we have to take care of them in environments that don't support their previous coping mechanisms. So our long-term care residents, once they get into nursing homes, they're at highest risk for not being treated for post-traumatic stress because we're healthcare. We are not emotional care. And also, most of them do not have a diagnosis of PTSD. So we can treat COPD, we can treat broken hips, we can treat CHF, diabetes, but we don't really necessarily know how to treat people with trauma symptoms. And that's why we are asking people to give us the opportunity to do this type of training, to educate folks. Medication is often overused and misused, and Sarah's going to speak about that, particularly with our elder veterans. And many veterans, like my dad, self-medicated throughout their lives to deal with their trauma. My dad had no idea that he had post-traumatic stress. He just knew that if he smoked and he drank and he took pills, that he felt better. And living in nursing homes, unable to self-medicate, it triggers the emotional issues that cause the intrusive memories. And this is why we have in our industry what we call and categorize behaviors. So post-traumatic stress and dementia, they both show up in our elders as anxiety and agitation. So anxiety and agitation is exhibited in several ways. A lot of folks who have anxiety and agitation do not sleep well, in particular people who have had trauma, because when they go to sleep, they can't control their thoughts, they can't control their dreams, which become trauma nightmares. So if you're not sleeping well, of course you become very irritable. And if you are on edge all the time because of your trauma, then you become irritable as well. There's a lot of anger in people who have trauma and dementia because they're not understanding the process. They're not understanding why they can't remember. They're not understanding why they can't remember their words. Our Vietnam veterans in particular are very angry. They're angry that they have not been recognized for their service. They never got a welcome home. And they've carried that anger and sometimes embarrassment for some veterans that they were never recognized for their service. A lot of people who have had trauma experience become very easily startled. The noises that we make are not. So, for instance, in our home, I had a veteran explain to me, when I hear the med cart go down the hall at night, I know it's the med cart. I know it's the drawers closing. But to my ears, what that sounds like is a gun. And so we really want people to understand and be more aware of when you're with someone who has had trauma or someone who has dementia, the noises that you make, the words that you use, the sounds that they hear, oftentimes go through a totally different filter than what we're recognizing and experiencing. Also, people who've had trauma and dementia are on the lookout for danger. They're wondering where the bad guy is, and they really need structure. And when they don't have the structure that they're expecting, they oftentimes feel unsafe. And one of the examples that we use is in our homes, we post a menu. And if the menu says you're having turkey, mashed potatoes, and corn, and the veteran comes to the dining room and you're having turkey, mashed potatoes, and green beans, they get upset. They're really not upset that it's not green beans or corn. What they're upset about is, you told me this is what I was going to have. I was counting on this, and now you took it away from me, so can I trust you? So we have to keep that into account. There's also a lot of pacing. Pacing for anxiety and agitation is really a good thing. So if you have a family member or you have someone that you're caring for that is pacing a lot, that helps to relieve the anxiety and agitation. So I strongly encourage you, as long as they're in a safe environment, allow them to pace. Also, there's a lot of heart racing, because when you're agitated or your anxiety is high, and Sarah will go into this in more detail, your amygdala gets fired up, which means your heart feels like it's pounding out of your chest. So that is a very disruptive feeling, and so that can cause behaviors to arise. And calling out for help is a really significant issue with people who have trauma and dementia. And I want to offer up a little story here for you that happened recently. We had a veteran who was in his room calling out, "Help me, help me." And the staff was very busy getting residents ready for lunch. And so I stepped inside the room and I asked the veteran, "What can I do for you?" And he looked at me like I had three heads and said, "Nothing." And I said, "Well, do you need anything?" And he said, "No." So I put his call light up next to his arm, and I said, "If you need anything, just push this button." And he looked at me and said, "If I need anything at all, I can just push this button?" And I said, "Yes, sir." He said, "Okay." So that took me about 10 seconds. Now, that resident may have called out for help again later, but what he was asking for was, do you support me? Will you call if I need help? And so I really encourage anyone who has someone that they're caring for in any environment asking for help, just ask, what do you need? They may not be able to tell you, they may not need anything, but just the reassurance of you stepping aside and saying to them, how can I help you, could really help relieve anxiety and agitation. So what are triggers? And we don't always know what triggers are for the people that we're taking care of, so we need to figure these out. So triggers are an event, a behavior, a person, a smell, or an item that reminds the person of the traumatic episode. So I had done rape crisis counseling previously, and I worked with a woman who had been assaulted in an alleyway. And during the assault, the trash truck was going by, and she heard that. And so after the assault, every time she heard the trash truck, she was triggered to be reminded of the assault. So it took a lot of work to help her to get through, to know that every time a trash truck goes by, that does not mean you're going to be assaulted. And other triggers could be things like ceiling fans. If you are taking care of someone who is a helicopter pilot and you turn a ceiling fan on, that could bring back a traumatic memory for them that they're back in combat and they're in a helicopter. In my family, this was bicycles. So my dad, when he was in Vietnam, he saw kids ride their bicycles up and put them against a building. They'd walk away from the bicycle and the building would blow up. So when my dad came home from Vietnam, we were not allowed to ride bicycles. But I didn't know this until 2010 as to why we couldn't ride bikes. So we did not know or understand that every time my dad saw a bike, he saw a child on a bicycle with a bomb. But my dad also saw a bicycle with a child on it, and the bomb went off while the child was riding. So every time my dad saw a child on a bike, he thought that the bike was going to blow up. So that was one of his triggers. So we need to know and understand what triggers are for people who are caring for who have experienced trauma. Other triggers can be Alzheimer's disease and other dementias, because as our folks are progressing through their disease and they're getting younger in their mind, they can be back at the trauma event. So we need to understand that as they're going back and they arrive at trauma, they're going to behave in ways of a traumatized person again. And also, if they don't have the words that they could use before to explain why they're feeling anxious or being triggered, then we as caregivers have to figure out what that is. And also, traumatic brain injury can cause triggers. So if you have someone who was fine 1 minute and then they fall and hit their head, and all of a sudden they're acting like the trauma has just occurred again, they probably have a brain injury. Older veterans and older adults with cognitive impairment have a lower threshold to triggers because they don't understand, they can't make sense of them, and they oftentimes don't have the words. And age-related stressors like death or significant illness of a loved one, health issues, loss of prior health coping mechanism by moving into a nursing home or an assisted living where they can no longer utilize their coping mechanisms that they used in the past. These are all triggers. So what can we do to help with triggers? If you have someone who starts to become agitated, you can see them twisting their hands or tapping their leg or looking around. Everything was fine the minute before and all of a sudden they don't seem fine anymore. What you might want to do is just approach them quietly and say, find your breath. Take a breath with me. Because when you approach someone in that manner and you say to them, find your breath, they're thinking, what does that mean? And then you say to them, take a deep breath with me, they're thinking about breathing in and breathing out. So it takes them off of whatever trigger that they had and thinking about something else. You also need to remind them where they are and that they're safe. So if you say to them, hey, it's okay, you're here with Kathy in Austin, Texas, we're okay, take a deep breath with me. That can be what de-escalates the trigger. And also be responsible for the energy that you're bringing to the person that you're caring for. So if you have someone that's triggered and anxious and you rush up to them and say, oh my gosh, are you okay? They're not going to be okay because they're going to think that something is wrong based on your behavior and your interaction. And also try redirecting them to a different activity or location. Oftentimes, if you have someone who is becoming anxious or they're becoming upset, if you just take them over to the window and say, oh my gosh, look at the birds, or oh my gosh, let's watch the cars go by. How many red cars can we see today? That type of redirection could be very helpful to de-escalating a trigger. So what we'd really like to do is proactively avoid triggers. So to do that, you have to know who you're caring for. And one of the things that we do in our veteran nursing homes is we have a military information tool that we put together so that we know our residents' military history. We want to know what branch of service did they serve in, what was their job in the military, do they know if they have post-traumatic stress, do they know if they have triggers, do they know if they have trauma nightmares. So we want to know as much about this person's trauma history as possible. And sometimes the person that we're caring for can't explain their triggers to us, or they don't know their triggers. And so we need to talk with the family members, because oftentimes the family members know the triggers better than the resident does. You also need to keep the people that you're caring for engaged. If you have an elder who's been traumatized and we don't have them engaged in doing things and being active, then they will be sitting down and thinking about their trauma. And that is a way to engage residents to avoid their triggers. We need to watch for changes in behavior, and it's as simple as hand wringing or up and down, one sitting 1 minute, standing up the next minute, wandering around the house, wandering around the building. We've got to figure out what's changed so we can figure out what not to do again the next time. We have to minimize loud noises. We've talked about that. You have to remove the resident from the location or the event, and remove external stimuli. So if you have someone who is watching TV and all of a sudden they become agitated, turn the TV off. If you are using the music and memory program and everything's fine 1 minute and you notice that the resident is agitated, remove the music. It could be whatever song is on has been a trigger. And be careful what's on TV. Please don't leave the news on TV if you have trauma survivors or people with dementia. They can't always make sense of what's on TV isn't happening right there, right now with them. And you need to know who can watch war movies, who can watch crime shows, who can watch the news. You need to be really careful about that. Again, reassure the resident of the location and reassure them and remind them of who you are and that they are safe. All right.
So there are several military installations, and they're called either Intrepid Centers or Spirit Centers. And what these places do is they take soldiers with traumatic brain injury or PTS, and they try to get, and they work with them to get them to return to duty. And the reason we mention this is because they have the luxury of doing brain scans on these soldiers. And they have found that there's 3 areas of the brain that can be affected if you have PTS, and they are actual structure changes. And when we talk about this, and we'll talk about dementia, you can kind of see where the tie is. So one of the areas of the brain that may be affected is the amygdala. And the amygdala is what's called your fight or flight. So when you're scared or startled, that's the part of your brain that's going to get fired up. And you're either going to decide if you have to run really fast away or if you have to stay and fight. So what happens with PTS is some of them have an amygdala that's increased in size, and everything's a threat to these veterans. Now, please let me add that there is no cure for post-traumatic stress. We can help manage the symptoms, but the only way to live with it is to talk through it. So you have the amygdala, or if your hippocampus is smaller than typical, then that veteran's going to have a hard time converting his short-term memory to long-term memory. So where did I put the keys? Where did I park the car? What did I have for breakfast? How do I get home from the grocery store? Those things. And then the third area of the brain is the prefrontal cortex. And the prefrontal cortex is divided into a left and a right side. And if what they see is a decrease in blood flow to the left, then that veteran's going to have a harder time finding words and with memory. Whereas if there's an increase in blood flow to the right, that person's going to be much more sad. So being able to do this, they have been able to identify medications that might help. So if you have an increase in blood flow to the right and that veteran is sad, then it makes sense that an antidepressant be given. We talked when we defined dementia about the fact that dementia is not a disease in itself, but a group of symptoms. There's about 120 diseases that have dementia symptoms, and these are just some of the ones that we deal with the most. So you can have vascular impairment, which means the blood flow to the brain is not good. You can have Lewy body, which is proteins that are in the brain that cause dementia symptoms. We're going to specifically talk about Alzheimer's and Parkinson's dementias because they both have plaques and tangles, and they affect the brain in pretty much the same way. So if you're looking at the way that Alzheimer's or Parkinson's dementia affects the brain, this is generally the path it's going to follow. So with both of those, you have what are called plaques and tangles that invade the brain and kill the brain cells. So plaques are literally just pieces of plaque in the vessels, and then tangles look like either yarn or spaghetti that invade. And generally, the first area you're going to find a problem is in the hippocampus. And this is where your short-term memory is converted to long-term memory. So like we talked about with PTS, where did I park the car? Where are my keys? Did I have breakfast? Those things. From the hippocampus, it's going to go to the Broca Wernicke area, which is considered your language center. So this is where you find words. In our setting, a lot of times we'll have vets that talk about their car or their barn, and it hurts, and it's awful, and it hurts, and I can't move. My barn hurts. Well, it's because the plaques and the tangles have invaded the language center, and they can't find the word arm to tell us it's their arm that hurts. From the language center, it's going to go to the frontal lobe, and this is where we grasp concepts, rationalize, and make plans. So in the same realm as the man that couldn't dress because he couldn't plan, if someone's living at home and you maybe kind of question, and it's a woman that has cooked large meals for a large number of people before, and you get there and it's Thanksgiving and the turkey's half frozen and the potatoes hadn't been turned on, it could be Alzheimer's dementia because it's hit the brain in the frontal lobe and they can't plan. And fixing a meal takes planning. From the frontal lobe, it's going to move to the amygdala, and that's where emotions are regulated. So just, someone that laughs when they find out their son has passed. It's not because they're proud. It's because they can't regulate their emotions. And then from the amygdala, it moves to the back of the brain, and it's called the occipital area. And this is where what we hear, see, and smell makes sense. And if someone is going to have hallucinations, it's typically when the plaques and tangles have invaded the occipital area that this occurs. From the occipital area, it's going to go to the cerebellum, and this is the part of the brain that holds your old memories, who your parents were, who your siblings were, who you married, when you married, having your babies, those kinds of things. And when that area of the brain's invaded, that's when you lose all of that. And from there, it goes to the brain stem, or the primitive part of the brain. And this is the part of the brain that tells your body vital functions that you don't have to think about. Heart beating, respirations, those things. So when those brain cells are destroyed, then that's when death from the disease occurs. Behaviors that we see commonly with PTS and or dementia, and after knowing how it kind of follows the track of the brain, you can kind of tell where they are when you see these. So the anxiety and agitation, the aggression, wandering, exit seeking, trying to get out of where they are, withdrawal and depression. When we instruct on this, we talk about what influences behavior, and 95% of what we consider behaviors are due to staff approach. It's because we get so focused on what it is we're doing and how we are doing it that we don't always remember. So it's coming up from behind, or it's hollering a little bit too loud down the hall, or not explaining ourselves well. Their military experience, their rank, and their trauma history play a big part. We had a veteran that was admitted kind of late in the afternoon, and so his first meal with us was dinner. Well, when the staff gave him his, was serving him his tray, he took the tray and he threw it. Well, everybody pretty well figured, you know, he's new, he didn't want to be here, so, you know, we'll give him that one. Well, a couple of weeks later, they're serving him his lunch, and he takes it and he throws the tray, and it nearly hits another resident in the head. So the nurse says, oh gosh, he's a danger to others. So she goes to call the physician and the family and let them know that we probably needed to send him out because he's being aggressive, and the daughter asked her. She said, well, you know, I understand, but, and that doesn't sound like Dad. Can you tell me what you served him? And she said, well, I don't remember what we were serving the day of admission. She said, but for lunch today we were having stir-fried chicken and rice. And the daughter asked, she said, well, was it white rice? And the nurse said, well, actually it was. And the daughter said, oh. She said, well, you do know that Daddy was a POW and that they would starve them for days and then give them bowls of maggots to eat. And, you know, white rice looks like a bowl of maggots. So their trauma history plays an enormous part in their behaviors. Internal and external factors. There is something called rational detachment, which means that every one of us has an amygdala, and every amygdala is made to work the same way. It's for us to decide whether we need to run fast and far or if we need to stay and fight. And I know that when I am startled or scared, that my heart rate goes up, that I get a little bit more loud than what I already am, and I need to get there fast. So what rational detachment is knowing that that approach, if I get startled and I run at somebody, I am not going to be beneficial to them. So rational detachment is me making sure that I don't raise my voice and that my approach is calm and purposeful. We also need to pay extremely close attention to the environment. We need to listen, ask questions, and give them time to respond. When we communicate, we have got to remember that how we say something is as important as what we say. And everybody knows this. Your nonverbal is as important as your verbal, and rolling your eyes isn't going to get you anywhere or make someone feel safe with you. We've got to remember personal space and touch. There are people that we can touch and people that we can't. And just because I'm okay with touching somebody or rubbing an arm, if they're not, it means it's not okay for me to do. There's the supportive stance that we need to come to people with is one of respect and non-threatening. So rather than come from the front, we need to come in at the side. We need to come in relaxed and keep about 3 feet of distance. Because if their arm reach swinging is 2.5 feet and I'm standing 2.25 feet away from them and I get hit in the mouth, that's really kind of shame on me. And to say again, we have got to remember that if we cannot secure the aggressor, then we need to remove all the potential victims. With our communication as well, we need to use simple and clear words, especially those with dementia. We need to give reasonable instruction for what the resident can do, and we have got to allow time to process. In our settings, we use a lot of medications, and sometimes we don't use the medications to the best of our abilities. And when we talk of the meds that we're talking about now are considered psychotropic meds, and those affect the brain. And there's a lot of chemicals in the brain, and these do something for those chemicals. So there's two groups of antidepressant medications that contain serotonin. And serotonin is the chemical in the brain that makes you feel better. So if you don't have enough, you're depressed. And these are SSRIs, and they're like Zoloft, Paxil, and Prozac. The other one that has serotonin also has norepinephrine, and that's like Remeron, Effexor, and Seroxone. And you would use the one with norepinephrine if someone was depressed and didn't sleep well, or depressed and didn't eat well, and you just needed a little bit of an appetite stimulant. We use these okay, but we could probably do better about being better about our assessment of depression and who could actually benefit from them. A couple of the classes of meds that we don't use, that we maybe need to be better about not using, are anti-anxiety medicines, and those are benzodiazepines. So that's like your Valium and Xanax and Ativan. We need to use these in the short term, not the long term. And what we find in our settings is that we use them for the long term. The other class of meds we use are atypical antipsychotics. So anybody that we have decided is aggressive, then typically we use the bigger gun medicines, which are these. And this is like Zyprexa and Seroquel and Haldol. Well, what happened was these medicines were used for people that have true mental illness. And during a mental illness, if you are in a psychotic state, whereas the reality in your world, in your head, is very, very different than is reality, you have too much dopamine. So if we have a veteran that we have startled and he swung at us, and it's been decided that he's physically aggressive, so we give him a low dose of Seroquel after the doctor orders it, then we lower his dopamine level. Well, if his dopamine level wasn't too high, then if we lower it, he's not going to have enough. And the first three side effects of too little dopamine are increased confusion, increased agitation, and a greater risk for falls. So we're not doing anything to help. We're just giving him 3 more problems to have to combat. Sleeping pills. The primary sleeping pill that's used is Ambien. And with our veterans, if you'll remember, Kathy said her dad couldn't go to sleep because of his nightmares. And that's what most of our vets do, is the nightmares are just horrible, and you can't control what you dream. So a lot of times we'll give veterans Ambien, and the first side effect listed under Ambien is increased in nightmares. So these men that don't want to go to sleep because they have horrid dreams, we give them a pill that's going to make them sleep and make their dreams worse.
Okay, so we're wrapping up, and I just wanted to end with survivor's guilt and moral injury. So survivor's guilt is a psychological syndrome. It's when people have done something to survive, but they feel that they have done something wrong, and that they're living, and people who've done the same thing are no longer living. So oftentimes veterans who've been in combat torture themselves with negative thoughts, thinking, why didn't I get hurt? Why did other people die? Why did the guy next to me die and I didn't? Could I have done something to prevent it? So a moral injury is when someone is asked to kill others and then comes home and is questioning why they had to do what they did. And a lot of us were raised with thou shalt not kill. And so when we put a gun in a 17-year-old's hand and tell them to kill, while they're in country, that makes sense. But when they get back home, they're oftentimes ashamed. They feel like they've done something wrong. They're violating the sense of what is right and wrong. And oftentimes, as they get to the end of life, their soul is in anguish. And so I'll share one last story with you about my dad. He's living in a nursing home the last 7 months of his life. He was in pain. He had stage 4 lung cancer. He really didn't have a very good quality of life, and he wanted to die. But he was afraid to die. And he was on hospice, so he spoke to his hospice chaplain and told him, I just am afraid to die because I'm not going to go to heaven based on what I had to do in Korea and Vietnam. And the hospice chaplain said, no, sir, that's not true. You defended your country. You lived honorably. You are going to heaven. But my dad had a really hard time acknowledging this and accepting that. And so what he needed to do is he needed to share his stories with me, he felt, to see forgiveness in my eyes. And he said if he could see the forgiveness in my eyes after he shared the trauma that he had, that he knew that he could go to heaven then. And so we shared some pretty traumatic memories, and it was really hard to listen. But it was really good for my dad to not only see forgiveness, but to see a deep, profound love that I had for him. And it was really good for him to know that not only did I love him unconditionally, but to have gone through what he went through and be a productive human being and a good man and a good father and a good husband was really good for him. And he died very short time after that in his sleep, not in pain and not afraid to die. And I share this with you because you will get people that you're caring for who reach the end of their life. And if they have, in their mind, caused trauma to other people, if they have not dealt with that, they too could get to the end of life and be afraid to die. And so if you hear people saying things like, I want to go, but I'm afraid, God, please just take me, I don't want to do this anymore, have a conversation with them or get them connected to people who can have a conversation with them to talk about what their trauma was so that they can let go of that and move to the end of life experience as they want it to be and get there with an open heart and an open mind and go through the process that's not emotionally painful. So that is our presentation. You'll see we have the military service information tool for you that you can utilize. This is a bibliography of our resources that have helped us do this training. Here are some videos on military trauma from all different wartime, and we open the floor up for questions.
Thank you. I certainly learned so much from this presentation, and I know we are at the 152 mark, but no worries. I know this presentation is slated to end at 2, but if you ladies are available to take some questions until then and maybe after, we're available. So if you have a question, please just type it in on your right-hand side, and I will be reading them. So far, we have great presentation and handouts. Noreen loved your presentation. Miss Caspi said, excellent presentation, very useful. So far we have really good praise. I'm sure everyone learned something new today. Okay. Could you please share your thoughts about the role of PTSD in vet-to-vet distressing and harmful incidents? This question is from Ms. Caspi.
Can you repeat the question?
Could you please share your thoughts about the role of PTSD in vet-to-vet distressing and harmful incidents?
So not only military trauma, I hope I'm answering this question properly, but trauma comes to people in all stages of life. And I was just reading an article that said between 70 and 90% of the elder population has had at least one traumatic experience in their life. So it starts with childhood trauma. If you are in the foster care system, you're at risk for excessive trauma. If you are a female, you have a higher risk of sexual trauma, assault trauma, domestic violence trauma, though men obviously do have that type of trauma also. And then as an elder, if you're under the care of someone and they are abusive to you verbally, physically, or emotionally. So those are the types of traumas that could be inherent in the types of people that we care for. Does that answer the question?
Well, we'll see if she types back, but thank you. Again, we have Cheryl wants to tell you, a wonderful presentation. I am living on Indian country, so we have veterans from all wars. Because of the tribal diversities, this is very good information. Thank you. So she's very thankful for all the information you shared. Ms. Leader, again, she's thanking you. She has a member, one of her members is a veteran, and so she's going to utilize all the knowledge you shared today.
Awesome. That's awesome.
So we have a lot of great feedback. Another question is that if a person is living with PTSD and dementia in a nursing home and the staff doesn't have training on this, do you recommend any sort of trainings that they could go through to better educate the staff at hand?
Well, we'd love to do the training, so that's an option. Definitely reach out to us if you would like to have this training for your staff. But there are, the VA.gov is a website that explains military trauma at multiple levels of wars. And also the videos that are on the end of our presentation could be a great way to engage your staff to understand the military experience. As far as other trainings go, I am not aware of any other trainings besides the Veterans Administration. And actually, Sarah and I are starting to train the VA's nursing home staff with this training. So I'd love to say that your best bet is to contact us.
Thank you so much. And I know your information is on these slides, which is available for everyone under the handout section. So back to Ms. Caspi, she responded to your previous response. Use her response. I was referring to what ways PTSD contributes to vet-to-vet incidents in CLCs.
I'm sure it has some bearing on it. If they haven't worked through their trauma and we've taken all their coping skills and they can't manage those feelings, then I'm sure PTS does have some bearing on vet-to-vet instances or incidents in the CLC.
And also, a little further into that, if you have officers and enlisted men and women living together, back in the day of their military experience, fraternization was not allowed. So now we have officers, what they consider to be fraternizing with enlisted people, and there is a hierarchy that goes between non-commissioned officers and officers. So that could play a role for sure.
Thank you so much. I have another question from Jennifer. Are there any programs available for the less severely cognitively impaired that focuses on counseling?
Not that we are aware of. We couldn't answer that question, I'm sorry.
Okay, thank you. Do you have any recommendations for a veteran with dementia in the home who keeps the TV on the news channel?
Well, you know, sometimes people with dementia see the news as what's happening right in front of them. So if you can't redirect that person to something else, if the news doesn't trigger a negative behavior, it's okay to watch. If the news is triggering a negative behavior, you've got to find a way to redirect that resident by either putting something else on the TV or getting them up and away from the TV.
Okay, thank you so much. Again, we're having a lot of shout-outs. Everyone loved your presentation that they're going to take to their settings and pass along to those in their professional circle. Again, we have I do have another question. Many vets are on psychotropics that may not be working, but the wait at the VA is so long. What can a family member do in the meantime?
Well, actually, in the meantime, all they can do, that I know they can do, is continue to give the meds prescribed until they can get in, but to work and try to figure what the triggers are, what it is, at what point in time. Does the behavior happen? Did I come up on the right side? Did I come up on the left side? Did he trigger this time but not this time? And it is such a hard process to figure it out. Such a process. But it's just a matter of that and writing it down.
And that's what we do in our homes, is we basically identify a behavior, and then we just continually ask, what happened right before? What happened right before that? What happened right before that? So that we can really go back and dissect what happened that may have triggered the behavior.
Okay, again, Ms. Caspi is saying, to what extent vet-to-vet incidents in the context of dementia is a concern in CLCs? She's now asking, any research done to examine this?
You know, we are not aware of any research. Again, we've just started working with the VA at their CLC centers through for this training. I can tell you that at Audie Murphy, a psychiatrist there, her name is Dr. Veronica Shedd. She has done some work on behaviors, and you might be able to reach her through the Audie Murphy CLC.
Okay, thank you so much. I want to respect both of your time, so I will be ending today's presentation. I want to welcome everyone back next month for December. We do, again, have these presentations the second Thursday of each month from 1 to 2 p.m. Eastern Time. I specifically want to thank both Kathy and Sarah for all of this information. Again, I certainly learned something new, and it appears that most of us learned something new today and really value your insight and the dedication to the vets that you serve on a daily basis. I want to welcome again everyone back, and I want to wish everyone a happy Thanksgiving. Thank you everyone for joining us today. I hope everyone has a great rest of the day. Bye.
Thank you.